and of course, investing in your patients by learning from the best speakers we have around the world. As you have curiosities, as you have questions, please comment in the comment section, and we will do our best at the very end as we have a Q&A. We're going to dissect through all of those questions and do our best to answer as many as possible. So I applaud you guys for joining us, and thank you. Of course, a little bit about myself. I am once again from Chicago, Illinois. I have had the great honor of speaking with BTL and alongside of them for a couple of years now. I have owned and operated over a dozen practices, many of which have been in medical weight loss, many of which have been also in aesthetics. I now do consulting all over the world to help practices adopt this technology and be very successful with it. And I cannot wait to learn from everyone that has joined us today. With that being said, I would like each of the speakers to take a moment to introduce themselves so we can go through who we're working with today and how we're going to learn from them. And I would love to start with Dr. Jennifer Levine with giving a quick introduction.
Hi, thank you, Sam. I'm so excited to be here. I'm Dr. Jennifer Levine. I am a facial plastic surgeon on the Upper East Side of Manhattan in New York in the USA. And the neck is like one of my passions. And I think someone asked me a number of years ago, like what my dream treatment would be. And it would be a non-invasive treatment to target the neck. So it looks like my dream has come true with this device. I am also the chair of the Emerging Trends in Technology Committee for the American Academy of Facial Plastic Surgery. So innovation and technology is my passion. And I'm so excited to share this latest and greatest device from BTL with all of you today.
Thank you, Dr. Levine. It is super exciting, isn't it? We've been waiting for our treatment to finally address this that has no pain, and I don't know, I'm getting a little excited about this whole thing. And
I know, no pain, no downtime.
I know, crazy,
yeah,
right?
This is, and it's really remarkable.
Well, appreciate that introduction, Dr. Levine. Dr. Rakesh Nanda is also joining us today, and I would love to have him have the opportunity to introduce himself as well.
Hi guys, so I'm Dr. Rakesh Nanda. So I live currently in Ohio. So we have 5 different medical spas. We have Columbus, Cincinnati, Dayton, Boca Raton, Florida, and Miami, Florida. So I'm really excited to be here today with all these expert speakers and all of you guys from around the world. So my background is internal medicine, pediatrics, specialty into aesthetics now and cosmetics. So we have a lot of different lasers, and I'm really excited to talk about this topic because this has been a topic of demand, and I think something that's really emerging among all of our patients. We have dozens of different devices that treat similar things in this space, but never anything at this level. So I'm excited to be here.
Thank you, Dr. Nanda. It's a pleasure to have you as well. And let's move on to Dr. Carolyn Jacob. I would love to introduce her and have her have an opportunity to let us know where she hails from, and I know it's close to home. And of course, let us know a little bit more about what she is all about and what she does.
Thank you. So I'm Dr. Carolyn Jacob. I'm a board-certified dermatologist. I'm the director of Chicago Cosmetic Surgery and Dermatology here in downtown Chicago. I'm also a clinical assistant professor at Northwestern University, so I help teach the residents. And we have a research facility within our business here called Chicago Cosmetic and Dermatologic Research. So we've been privileged to be a part of the research on this EMFACE Submentum device, and I'm super excited to share it with everybody today.
Thank you, Dr. Jacob. It's a pleasure to have you. Now, the next individual is someone that we have the, of course, pleasure of having because he's a very busy guy. I will admit I'm a little bit of a fanboy and maybe a little bit of a fangirl about him too, and it's a pleasure to finally have him live here. Without further ado, we have Professor Dr. Sebastian Codofana, and he is going to kick us off here with an introduction of himself.
Well, Sam, thank you so much. And it's a pleasure being here also with this esteemed colleague talking about this interesting topic, which I feel in the past didn't receive a lot of attention. And when it started to receive attention, it was always, oh, it's so difficult. There's nothing more we can do about it. So I'm very happy to share some of the small anatomical insights in this, and then to, of course, discuss how this can be translated to patient care.
Thank you, Dr. Codofana. So with that being said, thank you guys for all being here with us. As you around the world are watching, you can see that BTL does not compromise on the quality of individuals that they have on the team of investigative panelists and, of course, speakers and specialists around the world to talk about this hot topic. And let's talk about it some more. the EMFACE, of course, a device that you guys have come to know and love with, of course, bringing applications and applicators to the face to help non-invasively lift and help bring back that youthful structure that we are, of course, wanting to see more of as we age. But now, of course, we have evolved this device, and BTL has done such a good job of listening to the consumers, listening to the patients, and more so listening to the industry and figuring out what is it that we can do better for our patients and what is it that we can do better for our providers. So you all watching today can figure out what you can do to enjoy treating patients even more. And that has come down to today with the Submentum applicator. But of course, with the EMFACE and its evolution thus far, we're going to discuss a little bit more of how the Submentum is, of course, being engaged with this technology. And for us to be able to better do that, we have to understand the anatomy. We have to understand how is this technology being applied, but of course, where is it being applied? And how are the facial structures and the Submentum structures changing, altering, and how is this important for the treatment outcomes? And of course, we have the best and the anatomist here, Dr. Sebastian Codafana, that's going to walk through the anatomy so we can better understand, before we dive into the details of this product and this device and this treatment, what is changing, how are the structures evolving, and why is this important? Without further ado, Dr. Sebastian Codafana will take us through the anatomy of the Submentum.
Sam, thank you so much. I think it's always important to kind of start with the anatomy, not only because anatomy starts with an A at the beginning of the alphabet. It's also kind of like to look into the structures layer by layer, starting from superficial to deep. And the beauty about this one is I can do that with my patients, where I reflect everything and expose everything, whereas you might have some difficulties doing that in that extent, because putting it back for me, it's much easier. I don't have to do anything, whereas you need to take care of some certain aspects following this area. So I'm just going to give a quick update on the submental region. There are all my accolades, which no one needs to know about those ones. And of course, I'm just going to present on the anatomy only without influence on this aspect. And when you look into this area, I think it's most important to understand a little bit layer by layer approach. Most of you know I always talk about layers, and layers mean something that under the skin, there is something. And the things that are under the skin are arranged in a very specific ways, which you, of course, my esteemed co-faculty here, know very well from the surgical applications. But let's look at layer by layer approach from this one. So once we reflect the skin, we can see a substantial amount of subcutaneous fat. This can vary depending on age, gender, on the respective BMI. And under this, under the subcutaneous fat, you can see on the right image, there is the platysma. So we already have layer 1 with the skin, 2 with the fat, and 3 with the platysma. And this way, we're moving our way downwards. And the platysma, however, is actually consisting of 2 muscles, left and right, and they connect with each other. They connect with each other at different levels. Sometimes you can see this on the left image, the connection happens only at the mandible. So everything in between is just fascia, which we call the superficial cervical fascia. Or as you can see on the right picture, you have a lot of muscle fibers that cross, even cross at the laryngeal prominence. So all of this kind of like depends and gives support for the neck and how the structures are adherent with each other. Because the platysma, you can imagine, when it's connecting with each other, then gives more support than when you have 2 different aspects, left and right, which also influence, and you know it very well from platysmal banding, the prominence of the paramedian platysmal bands. Now, for instance, here, in this picture here, and I will try to let this video running if we can make this happen, which is going to happen right now. In this video here, what I did is I pulled on a platysma because my patient couldn't contract anymore. So I had to do the contraction for the patient, and you can see exactly how the platysma is moving. It's gliding on the underlying surface. And in addition to this, you can also see that an area in the center is not gliding a lot, whereas areas left and right can glide, which gives rise to the paramedian platysmal bands. Now, if we move into the next slide, you can see this respective arrangement, because in the next slide here, we can see in this video, what happened is I reflected the skin, I reflected the superficial fat, and then, well, having the instruments proper, I reflect the platysma. And look what happens suddenly. Suddenly we see another layer of fat. Another layer of fat under the platysma. And this is really important to understand that there is another layer of fat. This is called the subplatysmal fat. And if we move into the next slide, you can clearly see that once you reflect all of the layers, starting from the skin with the superficial fatty layer and the platysma, you can see that there's a substantial amount of fat. You have also the submandibular glands, you have vessels, you have lymphatic tissues, but then you have something very important there as well. You have another muscle. And this is indicated here, and it's only the anterior belly of a total muscle, but this is the anterior belly of the digastric muscle. Digastric muscle is called digastric because it has two bellies, and gasta means belly. So it's the anterior belly of this muscle. And what is very important to note that between the digastric muscle, there is fat, and anterior to the gastric muscle, there's also fat. But here comes another important feature. When you think about the characteristics of the muscle that you have, the platysma is a muscle of facial expression, whereas the digastric muscle is a skeletal muscle. And these two muscles are different in their behavior and are different also how they react to aging. At the moment, we know very well skeletal muscles, like the digastric muscles, are affected by a process that's called sarcopenia. Sarcopenia is very comparable to osteoporosis for the bones. Osteoporosis for the bones means that we lose bone mass as we age, which is hormonal induced. Sarcopenia is the same thing for skeletal muscles. We lose muscle mass of the skeletal mass as we age. However, muscles of facial expression, like the platysma, they do not, or at least at the moment, we have not discovered the process that is sarcopenia for muscles of facial expression. So that means the platysma. But the question is, then how do we receive support for this area here? Support comes from fat, because fat is not only there so we can complain about it. Oh my goodness, I have so much volume here. It's because of the fat. No, it's not. It's also because fat gives structure. Fat gives support. You can imagine you have the tire of a car, and when there's sufficient air, it's sufficient support, it's firm, it's stable. But when the air is moving out, then everything is not so stable. And the same thing you can imagine also with fat in a human body. It's not there to complain only, oh, there's too much of this. It also gives you support, stability, and consistency of the structure to keep them in a proper space. But in a submental area, what happens is the muscles, skeletal muscles, undergo a process of aging. So that means we lose support. And here you can see the muscles, how they all interacting and how they're all located in the submental area with all of the muscles which have so complicated names, which I don't know who named them. Look at this. Mylohyoid, hyoglossus, thyroid, omohyoid. I mean, these are all names which, honestly, my students hate them because they all sound similar, but they all do different things and they're all located differently, right? So these muscles affected by aging and sarcopenia lose their support, lose their structure, and lose how they should be positioned. And what happens to fat? Well, there was a study, I will not tell you who published that study a couple of years ago, but independent which BMI grade you are located in, independent if you're low BMI, medium BMI, or high BMI, as we age, we lose fat. And you might recall what fat is relevant for is to provide stability. So if you put off the things together, especially of the submental area, you have the fat that goes away, which then at some point we don't have stability anymore, and then also the muscles, which also move and have an effect due to the process of aging. If you put all of this together, it kind of makes sense why this area is so affected, because here everything can move downwards and follow the effects of gravity. So this is kind of like the quick overview of the submental area as it relates to the anatomy and of the submental region. And now I think it's important that we move on and connect with the clinical aspect of this respective area. And with this, I'm coming to an end of my presentation. I'm giving back to you guys.
Wonderful. That was honestly so crazy to learn so much in a quick period of time. And every time I listen to Dr. Cotofana speak and explain the anatomy, I always question myself on what on earth did I learn during med school? Because it's simplifying it that easily and that quickly is very, very amazing. I wish that you had taught me during med school, Dr. Cotofana. So I appreciate that. Thank you. With that being said, and with you now giving us a good foundation of these structures, and of course the Submentum and the different influences of this area, how would you answer the questions that we often get in terms of what is contributing to my double chin? I have this, it's all fat. I get rid of the fat, I freeze this fat, I melt the fat away with injections, but then also explain to them that it's not just, as you mentioned, fat related. There's a lot of anatomy that's contributing in terms of the actual muscle structures. But how would you best generalize the anatomy and the contribution to the appearance of the double chin?
So do you want me to answer that one, Sam?
Yeah, any of you, either Dr. Cotofana or Jennifer Levine, both of you would be great.
So I think when we're talking, Dr. Cotofana made a very important distinction into the structures that are pre-platysmal or above the layer of the platysma, and also the layers below, what's going on below the platysma. And right now, if we're doing a surgical facelift or a submental liposuction, we're targeting the platysma and the pre-platysmal fat, but we're not really doing anything to the structures below the level of the platysma. So often if someone fails like a treatment, even like a surgical treatment, it's usually due to structures in the deeper part of the neck. Now your body is very smart. The platysma is a main protection for the neck because all of the important structures of the neck are deep to the platysma. So all the glands, all the vessels, all the nerves are going to be deep to the platysma. So any important structure is going to be below this critical anatomic boundary. That's how even we decide when people need to go to the OR if they have a stab wound or a gunshot wound. They need to go to the OR usually if the injury is below the level of the platysma has been violated. Okay, so as long as you stay above the platysma surgically, you're pretty much not going to get yourself into big trouble. However, a lot of our patients may have structures in the deeper part of the neck that are contributing to the fullness, such as the subplatysmal fat, such as like descent of the digastric muscles, the position of the hyoid, and the submandibular glands. All of those structures also may need to be addressed in people who have these issues.
That's a great perspective. I think that a lot of people, of course, the public doesn't know this. And I think that this is so important for us to educate our patients on. But of course, we need to be educated ourselves because it's been such an area that we've neglected. Cosmetically, we've neglected in terms of our knowledge and understanding. So these sort of abilities for us to engage today and for all the people around the world for us to learn, it's important for us to know this, but also further simplify this to patients, making sure they truly understand how this can be applied and why it's important. With that being said, I definitely want to kind of dive into a little bit more of how the actual applicator works in terms of the EMFACE Submentum applicator. And I would love for Dr. Jacob to walk us through this application, what's been designed here, and why is it working the way it is, and what are we targeting?
Sure. Thanks so much. So we were very excited when the EMFACE was launched, gosh, a year and a half ago now, I think it was, about the radio frequency and high intensity focused electrical stimulation possibilities. The original EMFACE treats both the frontalis muscle and as well as the elevators of the cheeks, so the zygomaticus minor, major, and rosaurus. And this is all really important when you're trying to give tone back to these muscles because, as Dr. Cotofana already mentioned, we lose tone in the elevator muscles and we don't lose tone in the depressor muscles. And of course, as soon as this came out, we all raised our hands and we said, what about this? What about this? So it's really changed our way of looking at the Submentum because I've been practicing since 2000 after I finished my fellowship in cosmetic and laser surgery at Harvard. And I can remember doing neck liposuction, and we would do platysmoplasties as well. And the structures, we just didn't get beneath that, and we weren't getting the results all the time that we wanted to. And then fast forward, we've been working with dissolvers of fat, and we're not getting the results that we wanted. And there's some really interesting things that we'll talk about a little bit later about trying to define who's the best patient for this. But with the original EMFACE, we have the radio frequency, which provides this slow and steady, very comfortable heat, which is different than stamping heat methods, which have to go to a really high level in order to effect some sort of change, which makes it painful for the patient. So synchronized radio frequency with the high intensity focused electrical stimulation is very comfortable. And what they did was they took the pads and kept the cheek pads, because if you even just touch your cheeks and lift, where do you feel it lifting? You feel it lifting along your jawline. When you get to be my age, you do this a lot. Anyway, so we did that, and then they added a pad for underneath the chin. And with that pad underneath the chin, if you want to go to the next slide, you can see that the pad is very unique in that in the middle there is both this high intensity focused electrical stimulation, which is not targeting the platysma. It is targeting the digastric muscles. And as we already talked about, this sling with the hyoid bone starting to descend as we get older, you can imagine what that does to the cervical mental angle. So what we need to do is we need to tone that muscle, who doesn't have another way to exercise that I'm aware of, in a way that it can have maximum stimulation for best toning, not necessarily hypertrophy, but toning of the muscle. But at the same time, we wanted to give this radio frequency plus. Now, radio frequency plus heat creates a heat that is high enough to dissolve some of, or destroy, cause apoptosis to some of the fat that is in this area. But mark your pictures here, the applicators for the cheek don't have the RF plus. They are there to heat up the cheek skin to give more collagen and better elasticity to the skin in the cheek area. So we're only targeting the fat in the submental area when these 3 pads are put on the face at the same time. So go to the next slide. And so this is showing how we're targeting both that preplatysmal fat, that digastric muscle, which is allowing with its laxity to appear to be bulging out, which it truly isn't bulging, it's just lost its tone. And what we're targeting is both that fat and that muscle with the submental applicator that works with your original EMFACE device. And let's go to the next slide. Great. So this is how it works in basic. We want to talk a little bit about the studies as well. So I don't know if you want to dive into those slides now, or have a little discussion about the differences between the radio frequency plus the regular radio frequency, because I really want to hit home the point that we're not changing fat in the cheek area at all. We're only changing the fat in the submentum. And if there's no fat in the submentum, that's okay too, because the heat's going to improve the skin, and that elasticity kind of skin laxity study is currently underway.
No, I'm glad that you're going through these details, because oftentimes we have a lot of people, of course, a lot of injectors, a lot of providers will say, we have this applicator that we've been used to, and we're preserving the fat. How are we destroying the fat here? And the device, of course, has been designed, and of course, systems and applicators to actually increase that fat level, burning, of course, destroying it. So I appreciate you going through that. I actually want to kind of dive through, Dr. Levine, in terms of surgically, how is this changing the perspective of addressing these areas surgically, addressing these areas non-surgically, and how this truly differs with, of course, what Dr. Jacob set up with us with the heat, and of course, being able to non-invasively do this now.
So as I said before, remember, even when I'm doing surgery, most of the time we're targeting structures that are above the level of the platysma. So that preplatysmal fat, the skin, and the platysma itself. So this device has the ability to really target those structures that are below the level of the platysma, which we also could target surgically. That would be a deep neck lift. So that would be a procedure that would go below the platysma, and then we would be able to have to, do something to the digastrics to help tone them and lift them, or remove some of the fat in the area, reposition the submandibular glands. But all of those structures are in an area that we could never treat non-surgically before. I mean, it's difficult to treat them surgically. So where the EMFACE Submentum is really coming in is to tone the digastric muscles and to really change then the position of how they attach to the hyoid. Now, we have to remember that the hyoid is part of the laryngeal skeleton. And one of the ways that we determine who is even a favorable candidate for surgery or not has to do with the position of the hyoid. So if the hyoid is more anterior or the patient has a more obtuse cervicofacial angle, they are not as favorable as someone who has an acute cervicofacial angle. So the idea that we can reposition this hyoid and the digastrics, which, as I said, are technically challenging even with surgery, is really groundbreaking. Like, it's so exciting to really see that. And also, I think that it in turn gives us all a better understanding of the anatomy and how to get the best outcomes of our patients, for our patients, because we can't just look at the structures that are anterior to the platysma if we really want to contour everyone's neck.
Yeah, absolutely. And I think that's been some of the challenges when we were looking at necks before. People said, I don't like my double chin, but it's more than just that. It's
Right.
not just the fat. Some of you have muscle laxity, and this muscle laxity occurs as we get older. I start to look around with my friends and colleagues, and I'm like, oh, there it goes, their neck. And so this is something that's just never been looked at before, and it's amazing to be able to have a way to change the positioning of the hyoid bone to give us such better cervical mental angles, and with no downtime, no needles, no injections.
Exactly.
Absolutely. So with that being said, and I appreciate you guys giving this kind of knowledge from the clinical standpoint, I think it's super important. With all of these facts and with all of this knowledge that you guys are, of course, bringing to us, BTL, of course, doesn't just make claims. We know this. BTL proves the studies. They have so much investigation that is done. And I want to actually dive through a little bit of that investigation, if you guys don't mind. Maybe Dr. Jacob, if you can walk us through the clinical studies that have been conducted over the years and, of course, through the different trials and how we've gotten to today. Of course, with these theories and with these concepts that we're talking about, I want to actually show proof to it. Can you walk us through these studies a little bit further?
Absolutely. So this is great. I've always been impressed with BTL because they start at basics. They did this with their M-Sculpt device and their M-Sculpt Neo device. We were a part of all of those studies as well. And it just blows my mind every time how much I learn from what they're studying. So same thing with the EMFACE submental. They wanted to first look at animal fat histology. What is truly going to be happening to the fat when we put this RF plus in a particular area? What do we see? And Dr. Chris Robb participated in this study and found with the animals that were studied, they had a 4.8 times increase of the apoptotic level. Why is apoptosis important? Well, that is, we look histologically at the structures of the fat cells and see that they are broken open. They are not coming back. You don't really grow more fat cells as you get older after about age 2 and about puberty, unless you really gain a lot of weight. If you become obese, then you can have more fat cells created. But a lot of other devices that have treatments for fat don't actually show apoptosis. They show a shrinkage of the fat cells, but not an actual dissolving of the fat cells or breaking apart of the fat cells. So when you have shown that you've increased apoptosis, those cells are not coming back, that fat is going to be gone. They took it a little bit further and looked at these same animals and said, well, what's also happening to the skin? Because we've known since 2002 that radiofrequency helps the skin, and we want to ensure that we're getting an increase in the collagen and elastic tissue, because again, it's not just skin, it's not just fat, it's not just muscle, it's all of these things together. And what they found histologically in that study was an increase of 33% of collagen and 113% increase in elastin, which is great because people will always complain about the laxity of the skin. They'll be grabbing their skin and you can see it's already such a thin skin to begin with, at least more so in women than in men. That's some of the first signs of aging that you see. And in dermatology, we're constantly looking at the outer layer, the skin layer. But if you can increase that elasticity by 113%, that's a really good increase when we don't have other treatments that provide this. Then, of course, Dr. Goldberg looked at human fat histology. So what are we looking at here? Well, these are actually looking at enzymes that are upregulated when there is destruction or stimulation to destroy fat. And what they found was that the caspase-7 was upregulated by 5%. And this other one that helps as well was the prohibits was downregulated. The BCL2 was downregulated by 85%. And that's in human fat that was treated with the actual RF plus and HIFAS technology. So again, showing us that we're truly getting fat resolution as opposed to some other devices which might shrink the fat cells but not give resolution to them. Moving forward, the MRI study that we participated in, there's 3 clinical places that did these studies. We have over 50 patients that were involved in the studies. We're still currently gathering some of the information, but what's really exciting is, let's go to the next slide. I think you've got some of this here, is that of the 37 patients who've made it to the 3-month post-4 treatment mark, we have now seen a reduction with the MRI. The little gray blobs there are showing the before and 3 months after the 4th treatment, the MRI visualization of the fat of the submentum. And this fat pad in the submental region had actually decreased by a total of 13.6 cc's, excuse me. So you can imagine the volume reduction that is with somebody who has a generous amount of fat in that preplatismal fat. That's what we're looking at in the MRIs so far. We have not looked at any of the postplatismal fat in this MRI study, but we probably will take a look at those MRIs later because this is still hot off the presses here. These treatments for the patients, just to remind you if you're not familiar, are 20 minutes. They can relax in a quiet room while they're having their treatment done. There's no downtime with them. They do 1 treatment a week for 4 treatments in a row. And then after that 4 treatments, these patients were looked at, evaluated with the MRIs at 1 month and 3 months compared to baseline. And as with all of our other studies with the BTL devices, patients tend to improve at 1 month, but they had further improvement at 3 months. So that's why we're waiting for the rest of the information to get to us with the following patients finishing up here. But it's very, very exciting. So go back to the slide. Sorry, I was talking too long apparently. But the amount of fat reduction, there was actually a 36% double chin reduction, but then the actual fat volume reduction was 30%. So those are still our preliminary results because we haven't gotten all of the patients done here, but it's very, very exciting. And again, no downtime, you can go ahead, no downtime and no needles, no bruising, no swelling for 2 weeks after a treatment that has to be done 2 times in a row, 2 months apart. We've gone through all the treatments you can have. I love doing neck liposuction, but this isn't going to fix that muscle that we're seeing to help the cervical mental angle. And patients don't want to wear a head wrap for a week all day long after surgery. So a beautiful non-surgical result that we've never seen before. It's very exciting.
That was great. I think that the studies are critical, and I'm glad that these have been done. I'm happy to see all of these sort of outcomes and results. You mentioned neck liposuction. We're going to actually, I know the Q&A is towards the end, but I don't want to forget this question that was asked in the group, and I think that I would love to bring it up now. It was actually pointed for Dr. Cotofana in regards to the actual liposuction. I'm just going to read the question word for word. It says, if I understand correctly, Professor Cotofana, fat as tire support in the neck, if we delete it by liposuction or if we radiofrequency or ultrasound, would people lose this support? Also, to tone the digastric muscle, how long will it stay toned for? In these articles, they've shown that you lose 80% of the mass after 7 days of inactivity. Is this correct? Just kind of diving into a little bit of that support structure you were mentioning with that analogy and how liposuction may or may not impact this.
Well, real quick, go ahead, Dr. Cotofana. I'm sorry.
Oh, no, please go first and I'll do it.
I was just going to explain, like, part of the issue with the neck liposuction is the quality of the skin has to be taken into account. So for patients who have poor quality of their skin, the skin will always snap back, but only to a certain extent. And so you have to assess for that prior to actually doing surgery. And then taking into account that we're not getting at the post-platismal fat in a neck liposuction, we're also not getting at anything that's behind the muscle. You can see the limitations that we're having with just doing liposuction. Whether or not that would lead to more laxity, it depends on how lax their skin was to begin with. But go ahead, Dr. Cotofana.
I can just echo what you exactly said, because the studies have shown that when you do just liposuction, the results are sometimes inconsistent depending on the patient cases, what you have. And this is always the difficult thing about the submental area. Results are inconsistent. And And when we think about it, why do patients request this? Well, because they have too much volume here. But the too much volume that they have here could be from laxity or could be from indeed there's too much volume. And let's see, when they have too much volume, you reduce the volume, but how you redrape the tissues that were kind of like distended along the way. And a part of it, and this is the good effect of surgery, sometimes surgery leaves scars, and scars lead to contraction and to tightening of the tissue. But if you don't do additional measurements that you tighten the tissue, maybe with additional incisions or additional draping of the structures, then the results will be inconsistent. And now when we go to the first scenario where someone has just too much volume, it could be that the tissues are distended, you reduce the volume, and the tissues go back where it was, and then you suddenly have a good result. But again, if you think about it, if you don't understand the causes and if you don't treat accordingly to what the cause is, results might be inconsistent, and this leads to who is the right patient for the respective treatment.
I think also when you're doing submental liposuction, it's important not to over resect the fat, because then you're actually going to expose the platysma underneath more, which does not look youthful, because if there is any banding, it's going to become more prominent. So the idea is to create a more youthful contour to the neck, which involves softness. So over resection of fat during any type of submental liposuction is not encouraged. And I think it's also, it depends on also who's doing it, but the skin quality is very important, and not to over resect or damage the skin during the liposuction is also important.
Absolutely. I think consistency we're hearing is very critical, is being able to provide that consistency, and the non-surgical and surgical differences are clearly being understood better and better now. I actually want to bring in Dr. Rakesh Nanda, as we now have a good baseline and foundation set by our current speakers of the anatomy, of course, the clinical studies to show how this device is exactly working, the differences with heat being applied to the cheeks versus the Submentum. Let's dive into actually, how do we discuss this with patients? How are we selecting patients? How are we putting them into either the path of surgery or perhaps talking to them about this? I would like to bring in Dr. Nanda, kind of walk through his experience and how he is able to have selecting abilities with patients, making sure they are able to select the treatment that is proper for them, and how Submentum with EMFACE is going to be a treatment that we would be able to select for a patient. Dr. Nanda, could you walk us through how you do that?
Yeah, so you guys have all now seen a really good example of anatomic findings, the differences between liposuction and why it's so important to support all these layers. So I think first and foremost, we've never really seen anything that's addressed all of these submentum layers before properly like this, addressing the skin, the fat, the muscle, all at the same time. When these patients typically come in, they've pretty much done everything we've said in this. They've either tried liposuction, tried devices that have overflows or overheated the area, right? And so patients will come in and they want a nice jawline. They want a little bit more volume in the cheeks. Of course, they want to kill the fat. But is there anything that really addresses all these things together without having to do multiple different things? So being that our practices kind of address all of these different things, we found before that we have to do different devices and combine all these different things to try to obtain the same type of results as what we can find with the EMFACE Submentum all in one. So these patients typically come in and they want to address all those layers, but they don't know how to. They have never found anything that addresses all these different things at once. So these patients come in, they want to have those things done, and let's just say, we would give them filler and we would do Kybella. So let's just start with Kybella. And I love Allergan, I love Galderma, so much respect to all of our respective companies. We're all major accounts with them on this panel. But, not everybody wants the injections. They don't want to have the bruising. They don't want to have the swelling. They don't want to have the downtime. And we know that's a major problem. Not to mention there's a fear of needles. Let's just be honest. A lot of people are scared of needles, both males and females, particularly maybe a little bit more males. So I think this is a revolutionary process that addresses all those layers we talked about so eloquently here, but it does it all in one. And when you look at the male population, let's talk about that. A lot of men come in and they don't want to do 2 rounds of Kybella. They don't want to do multiple vials of filler. They don't want to do Volux for the jawline and then some Voluma on the cheeks. If everybody knows, we can do some math here. It's just quick math about how much this would cost. So 2 rounds of Kybella, plus let's just say some Voluma, some Volux for the jawline. You add all this up and you're way more expensive than what a single EMFACE Submentum treatment will cost, regardless of what your geographic area is. And so I think that this really filled a void for my patients that we could never address prior. And we have all of those devices, by the way. We have the things that freeze, that melt the fat, and all the fillers and the toxins. So this is the first time I've actually found something that can address all those different things together.
You're absolutely right, Dr. Nanda. I mean, as we understand the consumers in our world, in all of our worlds, I was just speaking with another colleague, Dr. JD McCoy, this past weekend. You were also there, Dr. Nanda. And we talked about how we're the crazy ones, right? We're the ones that think that needles are okay, that they're normal to input into people's faces.
Right.
Only 5% of the adult United States population, for example, does injectables. What on earth is the other 95% doing? They're scared. They're fearful, they're worried. Now we can speak to them. Now we can actually give them an opportunity to now address these areas without that fear, without that needle, without that cost. So I'm happy that you actually dove into that. With that being said, let's actually walk through some before and after photos, because this is where things get exciting. When you show before and after photos of this region, it really clicks. So Dr. Nanda or the other speakers, let's walk through these together.
Yeah, so anybody feel free to jump in, but this is a beautiful example of what we're talking about after 4 sessions. So again, once a week for 4 weeks straight. Look at that beautiful contour of the submentum, the jawline, also adding a little volume to the cheeks, all in one together.
This is one of our patients from the study, and it looks like she lost 40 pounds. She didn't lose any weight at all. We did all their weights prior to each treatment. And of course, this is only treatments that were done 4 times in 1 month, so once a week. And as you can see, Dr. Nanda pointed out, we're getting lift from the cheeks too, because this submental applicator only goes right here. It doesn't go all the way over on the jawline. But it looks like she lost volume. It looks like I did a liposuction on her. It looks like she lost volume on her jawline, and you can actually see the definition of her jaw now, which is amazing, because in someone like this, I probably would have thought, oh, they're going to need some jawline filler because they just don't have a distinctive enough jawline. But I think one of the things to remember when you're choosing patients for these treatments, I always have to feel the fat first. So I'll have the patient just let me feel the fat under their chin, and then I'll have them clench their teeth together while I'm doing that. And that pushes down unless you feel the fat that's outside of the platysma. And then while they're doing that, I'll have them take their tongue and put it to the roof of their mouth. And that also shows us some of the muscle movement that they have. And lately, I've been finding that some people who don't have a lot of fat have a ton of muscle sway. And I can tell that this digastric is really lost its tone. But in these people who are very, very broad-necked as well as broad-faced, I think this is an amazing option, because if you try to do Kybella on her, you're going to be sorely disappointed. And I have had a couple people where I tried to dissolve fat, and it doesn't work in these types of broad-neck, broad-faced people. You can see how much the muscle has to do with it.
Yeah, I completely agree, Dr. Jacob. We see that exact problem that you just addressed quite often in our practice, and we have to either dissolve that Kybella or see what we could do, and you can't.
For sure. No, I think that this is important. And Dr. Jacob, you mentioned with this before and after that we were seeing actual changes occur along the jawline as well by treating this area. I actually had a question. Perhaps Dr. Sebastian Cordofana can walk us through it. Of course, with the ability of the EMFACE treatment, we can treat 2 areas at once. So for example, submentum in the midface, or the midface, of course, the forehead. Is there an advantage of treating the midface and the submentum anatomically to be able to engage these structures for that proper lift? Or as we've seen, we of course can get some changes on the jawline with treating the submentum, but is there an ability or an advantage for encouraging patients to optimize the treatment by doing the midface and of course the submentum together?
I think this is a very important and very crucial aspect to understand, and also we all sometimes need to make the patient understand that when you treat another area of the face, especially those that are located higher, you will have an added benefit to whatever is below that. Because most of you know, when you treat for minimally invasive procedures, there are these 3 aesthetic principles, which are called lateral face first, upper face first, and deep regions first. And if you apply the upper face first principle, it means that because all of the layers are connected. You treat here, you tighten here, and this will have an indirect effect further downwards. In other words, treating the midface will have an effect on the jawline. And the reason giving is because there are layers in the face. Most of you know me, I always talk about layers here, layers there. But speaking in terms of really, I mean, first of all, the skin is connected. Well, surprise. And then what about the platysma? The platysma is continuous with the midfacial smas, which is then also continuous with the structures that are like high up here, like orbicularis oculi, zygomaticus major, or the superficial temporal fascia. So in other words, affecting these areas will have an indirect effect on the platysma, and we know that the platysma is responsible for tightening the submental region. So I do think, yes, there is an added benefit, and always keeping in mind aesthetic principle, upper face first.
Do you guys on the surgical side have any input in terms of that, in terms of when you guys are doing this surgically, and now we have the ability to do it non-surgically, are you addressing the areas simultaneously, and how would you translate that into non-invasive with EMFACE?
Well, like Dr. Cotofana said, this is a contiguous layer. So especially if you're doing it surgically or non-surgically, whatever you're going to do to the upper part of that layer is going to translate into the lower part of the layer. It's also important to note that the platysma actually inserts into the lower part of the face. So the platysma doesn't end at the mandible. It actually inserts into the lower part of the face. So that is why I would recommend, if you're going to do the submental treatment, to also do the cheek applicator, because it is going to help elevate and contour the mandibular angle and jawline, because those layers are connected.
Yeah, and 100% of the time I would always do these two together, because we saw in the original studies with the EMFACE the beautiful change in the jawline when we changed the cheeks. And we weren't expecting that either. So if you want to change the jawline and the submentum together, you definitely need to do the cheeks as well. And don't forget, a lot of your patients are going to be older than this patient. They're going to have some skin changes, and we want to give them that extra collagen and elastic tissue in the cheeks as well as the skin under the chin.
Yeah, I also agree with all the speakers. We've always done the cheeks and the submentum together in all of our studies in the beginning as well.
The question that we always get, and we saw this when the EMFACE originally released, was for all the injectors out there listening, even all the surgeons listening, they may sit there with curiosity of, is this going to take over my injectables, and or is it going to complement it, or how am I going to introduce this service without worrying about impacting my current source of service or revenue? I think all of you could probably speak to that. I would love to hear how it's changed so far, how you anticipate it evolving into your practice without it hurting your current passion of surgery or injectables, or how this adds on to it.
Yeah, I can take that first, I guess. So because we do so much toxins and fillers, I found that actually enhanced it. And the reason is, you know, Sam, you said that only 5% of people will come in and get injectables. So what about that other 95% out there that's floating around? I think those people now are encouraged to come in to try something like this because they've seen the results. They can get better results without having to spend all that extra money, plus no needles, no bruising, no downtime. And so then we kind of introduce them to other aspects, other things. Now they may be a little bit more comfortable saying, okay, I look good, I feel good. Now maybe they will try a little bit of Botox, or they will try a little bit of filler later if they need it. So we've actually found a rise in this because we've actually brought people in that were very hesitant prior. And then they get more accustomed to what we're doing, and they're more open to trying something new. Also, with our people that we've done EMFACE, Submentum on, and even EMFACE in general, let's just say, we saw that a lot of these patients were then more open to try other things. So we started with the EMFACE, and then we moved them onto Emcella and other devices and gave them a demo, of course, right? So not moving into any of that. You know, also even the Exion around the eyes was a beautiful complement here. And we could add a little bit of Botox later to certain areas and help them. So I think it's actually increased our business.
I think that's great. I think that you're absolutely right. I hear that repetitively and consistently with people introducing it. And of course, the fear is always going to be there of how this impacts, but it's only going to impact the patient's results positively, hence your business positively. We have a couple more before and afters, and I believe, Dr. Nana, this one's yours. Can you walk us through this one?
Yeah, this was actually a male patient. We actually chose this picture to share in this presentation. particularly because I think the male population is something that all of us should really look into. I think it's very underestimated. Men, as we all know, we like to have things done, but we don't like people to know that we've done things, right? We're very vain, and we just want everybody to think that we look so good without having to try anything. So women may be a little bit more like, hey, open, and they'll talk about it, but men, we like to hide certain things. So let's just be honest. That's why I chose this picture. So this gentleman actually in particular had come in, and he had tried other things before, all of which had failed. He came in and did 4 EMFACE Submentum. This was actually the fourth, this picture is actually the 4th session. Amazing results, a little bit different views. So you can see anteriorly here how he looks, and he's just over the moon happy.
You're so right about the male population. I think that it's been difficult to be able to target them, speak to them, give them an opportunity. Now, as we are evolving and the technology and the social media and digital arena is growing, it's not that men don't have those feelings. It's that they have the scare tactic or the fear of going in. And so Dr. Jacob, Dr. Levine, what's your input on specifically the male population? And then, of course, we'll dive into that last photo as well.
Yeah, 100%. And I wanted to comment on this patient. If this was before his 4th treatment, he's going to get even better because, as we saw, they had more improvement at 1 month after and at 3 months after. And so we have a lot of male patients here. And you're right. They're busy. They want to have no downtime. Some of them are okay with the injectables. Most are a little wincy about it. And it's hard. You know, they want to get something done. They don't want anybody to know. And they want to look great. So I think this is a perfect treatment for your male patients. The other cool thing is that because men have thicker skin, they're more likely to get even more improvement on the skin in the submental area with that radio frequency because it's easier to thicken their collagen because they started off with more than a thin-skinned female's neck would have.
Wonderful. And I believe we have one more before and after. I believe it's Dr. Levine's. Can you walk us through this one? I mean, look at this jawline. That's phenomenal.
So what I like about this patient is this is not a high BMI patient to begin with. So this is a thinner skinned patient who really has isolated submental fat and maybe some mild laxity. And it shows you how effective the treatment really is at reducing that fat and also at tightening and defining the jawline. So again, this is a patient that you could see not only the improvement in the submental area, but if you look at the definition along the jawline and even the cheek, you could see how much more defined that line is of her mandible, and it doesn't have all those irregularities that really make it look much more youthful and contoured. So this is not a treatment that is only for high BMI patients or patients with thicker skin. It still is going to be successful in people with isolated submental fat and some laxity, which is a high percentage of my patients.
And I'd also add, I think that her jawline looks amazing.
Yeah.
For a lot of these people, too, it's very easy to sprinkle in a little bit of neuromodulator to the DAOs and the platysma, too, to improve the overall pull down from the platysma and the jawline itself. And we have so many patients that just don't want surgery. I will send them to you, Dr. Levine, when they do. They're just looking for anything they can do to help out with the neck and the jawline without surgery.
I agree.
I think that this is so complementary to a lot of other things that we do too, because I just had a conversation with a person 10 minutes before getting on this about the layers. So I'm using Dr. Cotofano's language now, but this is muscle and skin and fat. There's 3 different layers. We have other things we can do also for the skin, but if you're really going to look at all of the layers, you're getting 3 layers with this particular treatment. And then we can move on and talk about other complementary treatments to be done as well, such as chemical peels or any of the other neuromodulators and other areas of depressors.
Right. It certainly is very comprehensive, right? Other things that we've done so far has been very isolated to either skin or filling or fat reduction, but now we're, like you mentioned, we're able to address all of those layers simultaneously and then tweak as we have been with injectables and so forth. Dr. Levine, did you have something you'd like to add?
I just wanted to say that, first of all, it's important for our patients to understand that all layers of their face are aging. So Botox and fillers are only going to address certain parts of the face. They're going to address volume loss and they're going to address muscles of facial expression. Botox or other neuromodulators are very complementary with EMFACE because EMFACE is primarily treating the elevators of the face, while we're going to use the neuromodulators best in treating the depressors. That's why they would be so effective for the DAO or the platysma or the corrugators. So these are treatments that are going to work best together. And it's important for us to educate our patients about the layers. So even if they're like, well, I don't want to know about that, well, they should, because that layer of their face is also aging. And if we're really looking for a rejuvenated, youthful appearance, we have to treat all of the layers.
Speaking of all of the layers and treating them together, we have had a lot of attendees that are watching right now ask us, what goes first? Does the radio frequency happen, or does the HIFES happen, or are they emitted at the same time, and why? Can we walk through a little bit of why it's been constructed the way it is, and why they are performed together, and what the opportunity is of emitting both technologies together?
Sure, and I hope, hopefully I didn't misspeak, but I wanted to clarify that this is a slow and low kind of radio frequency heating. So in doing so, it's not painful to the patients at all. And you've got the regular radio frequency on the cheeks while you're having the radio frequency plus on the chin at the same time. That's going to help to decrease the fat. But at the same time, the HIFES technology is coursing through a sequence of pulses. So you'll have the cheeks have a little bit of tone, and then the submentum have some tone, and then they have it together, and then there's a pause. And it goes through several cycles of that over the 20-minute period. But at the entire time, the radio frequency is being emitted, and it kind of starts out a little low, and it gets up to its effective temperatures within about the first few minutes, like 3 to 4 minutes. It's going to be up there starting to have its effect on boosting collagen and elastic tissue, and then starting to cause that apoptosis in the fat on the submentum.
Thank you for clarifying that. It's, of course, what's great is that this is convenient. Right now, we haven't really talked too much about the patient experience, but BTL has never ignored that. They wanted to make sure that the results are being shown, the technology is doing its job, but it's convenient for the patient, comfortable for the patient, time effective and efficient for the patient. With that being said, that comes to the question of a lot of individuals asking, what's the perfect amount of treatments? Of course, the studies have been based off of 4, but as you guys are experiencing this with different age groups, with different either male or female, is there a secret recipe to the amount of treatments that should be conducted in order to achieve the best results? Or how do you guys as providers navigate through that for each of your individual patients in diagnosing what amount of treatments they'll need to perform that optimal outcome?
So I can start. So all the studies were done with 4, so that's traditionally what we started with. Sometimes I find in a little bit of a more stubborn fat that they want to go to a 5th or 6th session. There are some patients we've actually tried up to 6 in. The results were great, but that's very specific. I think the majority of the patients, I would like to say, can be treated well in 4 sessions.
Absolutely, and we've seen that, of course. Just like anything, more treatments, the better results. And of course, we have to utilize our intuition to understand what their results are looking for and what type of outcomes they're expecting. With that also being said, let's kind of dive into a few more questions as we transfer into the Q&A piece of this. We're going to do our best to try to get to as many questions as possible. We actually have one that I'm reading right now that's at the top of my screen, Ms. Sharina from the UK. How does the treatment impact a patient with dynamic platysmal bands? Does EMFACE Submentum bypass platysma and target only the digastric muscle? Any of you that have experience with this would love to hear how we can best answer that question for her.
I'm happy to go if you like. So yeah, it's not doing anything to the platysma muscle. So if you have somebody who has platysmal banding when they talk, then they still would be a candidate for neuromodulator there. This is specifically going just to the digastric muscle alone. And that's why that HIFES is directed towards just the little branches of the nerve that are going to be right to the digastrics.
Wonderful. Thank you for explaining that a little bit further. How about individuals that perhaps have very minimal amount of fat, but still want that structure? Are they not a good candidate? And is there ability for us to maybe alter the treatment to really accommodate for this crowd, or are we just kind of not applying it to them? Can you walk us through those individuals that don't have as much actual fat, but perhaps still want to contour that area? Dr. Levine. I think you're muted. Thank you. There we go.
So I think even if the patient does not appear to have a lot of submental fat, they are still going to benefit from this treatment. This is still a treatment that is going to contour the neck. So even in the thinnest of patients, there probably is some mild fat that is contributing to the appearance of the neck. And in addition, the RF and the treatment of the digastric is really going to help recontour that. So I have treated people who are quite thin with this treatment, and they do look much better, and they do very well with the treatment.
Yeah, and remember the radio frequency is adjustable per patient, per site. So you have 3 different adjustments for it. So you can adjust down a little bit on the submentum, but you're right. I think they all have a little bit of fat there. And you do want that collagen and elastic tissue promotion, which you can get below 43 degrees Celsius. So even with the slower kind of radio frequency, you're seeing that in the submental area. But it's that tightening of the digastric muscle, I think, that's really giving you the home runs with these patients as well.
Yeah, I agree too with that, Sam, that, even the patients that may not have as much fat, I would still encourage everybody to do 4 sessions once a week, because we're addressing that skin fat and also it's not just about the fat.
Absolutely. No, it's of course we have to make sure going back to what we've kind of repetitively and consistently said, it's not just focusing on one layer, we're focusing on all of them, and they're going to benefit at some degree with, of course, the alterations of those layers. Now, let's just take a step back. We have all of you guys as experts in your arenas of surgery and medicine and, of course, dermatology. If we were to take a step back, you guys are the experts. You guys are the providers. You guys have done all of these treatments with surgery, with injectables. How do you see this being integrated into a practice? And now they can actually do this and maybe even delegate this to somebody else. We're now being able to change the appearance of people's faces and allow them to achieve these results without having to do it ourselves. How has that really spoken to you as technology continues to evolve and as BTL really continues to strive? How is this impacting you guys on a business level with integrating technology to free up your time or be able to do something else and continue delegating this down? Walk us through your experience, and perhaps Dr. Jacob, we can start with you.
Get off mute there. Yes, I have in my practice physician assistants who actually perform the treatments, but they're experts in body contouring and have been experts in the Emsculpt, the Emsculpt Neo, and then the EMFACE because they've been well trained along the way. But it's great because patients come to me for the consultations, and it ends up flowing that they need things that I can do, and they need things that the PAs can do as well. So it's delegatable. I just think that they need to have a thorough evaluation by an advanced practice practitioner, just to ensure, remember, we're dealing with high intensity focused electrical stimulation, so we don't want to have any large metal in the face. There are contraindications for patients. We don't want them to have metal between the area that's being treated and the grounding pad, but I think that it blends in well, and it kind of merges and marries well with what each side of the coin does here in the office.
And from a surgical perspective, Dr. Levine, how do you continuously see these non-invasive technologies being adapted into the practice? How that changes what you do?
So one of the things that EMFACE in general is really good for is either treating people before surgery or treating people who have had a surgical procedure in the past. So some of my best results have been on patients who have had facelifts, done elsewhere, who are looking for improvement. And those patients with EMFACE do really, really well, particularly also if there's any asymmetry to their face or there's any differentiation in how the face is moving on either side. This is a really great treatment, and it often makes the patient look better, not only at rest, but also in motion. So this is something that really plays hand in hand with surgery. It's not a one or the other.
Well, thank you for that feedback, both of you. Dr. Cotofana, I have a question. As technology continues to evolve and as we see non-invasive approaches to addressing facial anatomy continue to evolve, you of course have that history with injectables and how that changes the face, and surgery and how that changes the face. What do you feel the next years ahead are going to bring in terms of the non-invasive abilities to help contour and restructure and develop the facial anatomy? And do we think that this technology will have a long-term effect to the actual anatomy, or have you seen any of that? And what can you, if with your background or your knowledge thus far, see what is the long-term effects this will have, positive or negative? Of course, with now moving away from the scalpel and away from needles and more towards energy-based devices to help change the face.
Well, I think we've already seen a trend starting with more and more either minimally invasive or non-invasive procedures. They're becoming more and more popular, and one of the reasons is also because the patients like it. In the past, and I compare this always when you have a hammer, everything looks like a nail. In the past, the only thing that we had available was a scalpel, a knife. So then everything what we were trying to do was based on a scalpel. And now suddenly we have needles and cannulas, and we have soft tissue fillers, and then wow, now we want to fill everything that we can see. Every problem needs to be filled. Well, we see the outcomes. And now we suddenly start to see, well, what about repositioning? We have biostimulators, we have now other minimally invasive devices which help to reposition so we can rejuvenate the facial structures. And now if we move further now, we don't have to do anything because everything is non-invasive, like with energy-based devices or maybe with other procedures that might come in the future. But I do think we have understood that whatever we do to the tissue, surgery, minimally invasive or other, we also influence it. And sometimes it's not always easy to see the immediate effects or the long-term effects. We just don't see this. For instance, in my patients, I don't see fillers, but I suddenly start to see breast implants in my patients. But how it's going to be in a couple of years later on, maybe then I will see a lot of fillers and then some other things coming on, because at the moment we cannot really predict what the long-term effects are. Because for instance, one question that I saw in the chat is, what is this doing to bone homeostasis? Will it affect bone? Will it affect the fluid flow within the bones? These are all things at the moment we don't know, but I can promise you the future is very exciting. And I think that a lot of companies, including BDL, they're going into the right direction. And for me as a researcher and all of us here in the panel, it's really exciting and looking forward to the future.
We appreciate that insight. A couple more questions before we embark on closing this out. Before we answer the last few questions, at the very end, there will be a survey of your experience, and we certainly want, BTL would love you to stick around, don't close out of the chat as we kind of go through our final discussions here. In terms of the proximity of where we are treating this, of course, people that are getting new to this technology may have concerns about the impact it has on the thyroid gland, as an example, or the impact it has on the overlaying or underlying areas that we have to be concerned about long term. Of course, the electromagnetic, it's electrostimulus, so of course, HIFS technology. But can you guys that have done some of the research maybe talk on how BTL focuses on the long-term impact and to avoid making sure there is no impact on, for example, something like the thyroid?
Sure. With the radiofrequency pad, it's not near the thyroid. So the dissipation of heat, we do have some improvement of collagen and elastic tissue distal in the skin, distal to where the pads are on the cheeks, that was noted from the original EMFACE studies. But there isn't any change that's going deeper than the skin in terms of the heat for the fat lower, distal, not deeper, for the placement of the pad, because it's way up here underneath the chin.
Okay, we appreciate that. Definitely. It's always, of course, BTL has over 500 engineers and so much science. And of course, you guys as the clinical investigators to check all of this out. You know, they have designed these things not overnight. They have had put so many years and effort into this and to make sure that our patients are going to be safe long term. Dr. Nanda, as we start to close out this morning or this evening, wherever you are in the world, can you walk us through the business side of this in terms of, okay, we have this tool now. Is this area going to be a continuous popular area? And of course, with people becoming more digital, getting their phones out, taking selfies, of course, being on Zoom and webinars like this, we're all looking at our area. But from you've had so much history in the evolution of aesthetics. How are you seeing the trends change, and how do you foresee them continuing to change with addressing the Submentum, and now with this application, it changing even more?
Yeah, that's a great question. So we know there's hundreds of devices out there, and you know, in this space, there's only one that addresses all these layers. So I really, first and foremost, like to applaud BTL and being the forefront of technology, research, innovation, and protection, and really staying ahead of the game. So I think this is an amazing opportunity, just like I mentioned earlier, particularly with the male population, because that is really the low-hanging fruit here. But I just see things evolving so much because, you know, you get these patients in addressing these 3 layers, and then on top of that, we can add in other entities. We can mix in other devices we have, peels, facials, red light bed, so many different things that I really see this being kind of a gateway drug per se. They're going to come in because now we're, for once, chiseling up the jawline, killing the fat, really adding volume to the cheeks. And they're just going to love what you've done because you've actually addressed something that many of these patients have sought after for years. Failing Kybella, getting liposuction that may not have been even, it may have not properly addressed things, spending tens of thousands of dollars. And now you can address all this together within a month. And then the results keep getting better, right? After 3 months, you bring them back again, and now you really see good results. So I think you've pretty much gained a patient for life here. And that, for me, is a great business aspect because now you've really encouraged that trust and helped them along that journey.
That's a beautiful explanation, Dr. Nanda. We're going to end with this question. In terms of, as we embark on this new treatment, patients are going to always ask the lovely question that we get is this permanent? Is this the only time I need to do this treatment? Am I going to be perfect after this? How do we engage with all of you guys in your experience on, of course, surgically, dermatologically, and of course, medically? How do we have these conversations with patients and making sure they understand that the anatomy of the face is going to continue to age? These layers that Dr. Cotofana went through is going to continue to age. How are we explaining for the people that are asking in the chat, is this a series of treatments and we're done? Or are we maintaining it? If so, how are we having these conversations? And how is that maintenance protocol looking for you guys? Can we dive into that? Perhaps Dr. Levine, you can start us off.
Well, I think that's a great question, and I get asked that question all the time. And the real answer is we're aging every day. So nothing, we are going to continue to age. So that means that since we don't have a cure for aging yet, we are going to have to do certain things just to maintain how we look. Now, we know that these changes from the EMFACE are stable for at least a year, so I tell that to my patients, but we have to know, are we comparing apples to apples? Is it like a 60-year-old person who's never done any treatments? Is it a 30-year-old person who's been doing stuff? So we have to know who we're treating and what other treatments they're doing so we could determine the best treatment plan for the patient. So yes, they are going to have to do other treatments because we don't have a cure for aging.
Mm-hmm. Perfectly put. Dr. Jacob, anything to add to that?
Yeah, so just with all the rest of our treatments, muscle has memory, so I kind of start off with that. I do agree that it's difficult because if you're 70 years old and you're 50 years old, there's a 20-year degree difference of thickness of the skin and strength of the muscle, et cetera. But we tell people you're going to be doing maintenance treatments, just like going to the gym. This is something you want to maintain. You know, the fat loss will be there, but if you want to maintain the positioning of the hyoid bone or that tone of the digastric, then you do need to continue doing maintenance treatments. We're doing them for most people every 3 months, although I do have some people that want to do it once a month. So, you know, if they like it and it feels good and it continues to improve their skin and the tone of the muscle, they might as well.
Thank you, guys. Well, I know we are just coming up on time. There's been a lot of questions, of course, that you guys have been asking, which we greatly appreciate. They will not go unanswered. Certainly reach out. BTL has a track of this. We reach out to either one of us. You guys have our Instagrams that were posted in the chat. Reach out to your local BTL rep to ask these questions, and they will put you in touch with one of the experts. And further, in regards to adopting the technology and pricing, I know there are a few questions on that. Of course, reach out to your local BTL rep to make sure you're able to get those answers. We do not want to leave any of them unanswered. I know for many of you, it's the middle of the night, and I really applaud you guys for investing in yourselves by attending this. Dr. Nanda, Dr. Levine, Dr. Jacob, and Dr. Sebastian Cotofana, it has been an honor to have you guys today. And we thank you for investing in the entire world and bringing your expertise to BTL. And BTL, thank you guys for investing in all of us by hosting webinars like this and educating people on how we can evolve our patients' lives and how we can evolve our practices and ourselves as experts. Thank you, BTL, for hosting this. As mentioned earlier, please do not exit out of this. There will be a survey to get feedback, to get contact information so we can answer these questions. Once again, thank you to my esteemed colleagues, BTL. For those of you around the world, you guys are the reason we do this, because you guys are the reason that we have this industry be so great. We love all of you. We love BTL. And thank you guys. Good evening, good night, good morning. And we look forward to speaking to you guys real soon. With that being said, we are signing off. Have a great, great day. Thank you all.
Thank you.
Take care, guys.
Bye.